Afiq, can you, I think we can allow the participants to come in, Afiq.
Okay, saya sudah go live.
Okay, Dr. Habibah and Mina, we will let the participants join first. Around 3 o'clock, then we will start as planned. Is that okay?
Okay, Dr. Mina.
Okay, good. Thank you.
Today we are going live on YouTube, not Facebook.
Or on YouTube.
Yes. Correct.
Okay.
Mina.
Yes.
Mina, you want to mention later, say that we are going live on YouTube, I think from today onwards, because say that time we don't want to do Facebook anymore, remember? But I think eventually the video we will still post on YouTube, but then I think live on YouTube also lah. Because a lot of people don't have Facebook page. That was the issue.
Okay.
Dah mute kan?
Okay, so it's 1 more minute to 3. I think we can start now. So good afternoon to all. I am Dr. Nina. I'm from Taiping Hospital, co-host for today. So welcome to weekly webinar organized by Academy of Medicine Malaysia. Today we will continue with rheumatology topics. The topic prepared today is approach to joint pain and will be presented by Dr. Malik from Selayang Hospital. So without further ado, it's my pleasure to introduce Dr. Habibah. Dr. Habibah Muhammad Yusof. She is from Selayang Hospital as well, and she's a consultant rheumatologist and physician there. So with that, Dr. Habibah, it's all yours.
Thank you, Dr. Mina, for your kind introduction. And thank you, Academy of Medicine, for organizing this continuous talks throughout. I think this is something very important and very timely. And as for this month, is the Rheumatology month. And as for today, we've got this approach to joint pain. And allow me to introduce Dr. MALEK FARIS. Dr. MALEK FARIS RIZA FEISSAL bin JEFFRIZAL. He's a consultant rheumatologist at present at Selayang Hospital. He graduated from UKM and did his master's in medicine in UKM as well. He has served in a number of hospitals around Malaysia, and his interest, he's quite interested in presenting, and I am sure that you will learn a lot from his talk. So without much further ado, I would hand over to Dr. MALEK for his presentation.
Okay, Assalamualaikum and good afternoon. Many thanks for the invite. So as the topic says, it's an approach to joint pains. Of course, I am not able to put in on all the aspects of the approach to the joint pains, but I will try to summarize and give a concise review of what is expected. And of course, if anything else can be built out in the question and answer session later. So now this is a very busy slide, but this is to show that joint pain is, there's many reasons for joint pains, ranging from infections to crystal-induced synovitis or systemic diseases, Spondyloarthritis, vasculitis, and endocrine disorders. Now, the reason we put up joint infection is because that, as opposed to the other differentials downstairs, where the treatment is basically painkillers and sometimes immunosuppressive therapy, we must bear in mind that infection has to be ruled out if there is a suspicion, because of course, if you were to put a patient with infection with immunosuppressive therapy, you will worsen the infection. So just bear in mind that lah. So this is another more smaller slide to show that there are various types of diseases that can come with joint pain, and that it's also something as a wake-up call to actually further delineate these causes of common joint pains in rheumatology in terms of the chronology, whether they are inflammatory or not, the pattern of joint involvement, the symmetrical of the joint involvement, whether they involve the spine, and any extra-articular manifestations such as subcutaneous nodules, mallow rash, eye involvement, nail involvement, and so forth. Okay, another way of sorting out this list of diagnoses is to divide them accordingly in terms of chronicity or acuteness of presentation, whether it's a regional or systemic manifestation, and of course, whether it's inflammatory or mechanical like joint pain. And another evaluation is, of course, as any other medical illnesses, is to take a good history, whether it's past medical illnesses, history of certain diseases like peptic ulcers, allergies, family history, level drug history, a thorough physical examination of the involved musculoskeletal system, and other associated systems like the heart, lungs, and so forth. And finally, to review the blood tests and whatever imaging modalities that are present. So examples of such relevant illnesses like taking a history of psoriasis to look for in cases of psoriatic arthropathy, metabolic syndrome like diabetes and hypertension that is usually seen in psoriatic arthropathy, taking into account whether they have any comorbidities like ischemic heart disease, heart failure, CKDs, or fatty ulcers, as they are going to be on NSAIDs or COX-2 inhibitors, taking a history of smoking that will flare or worsen most autoimmune diseases is quite important too, or drug history like certain drugs that can flare gouty arthritis such as thiazides or pyrazinamide. Another one, of course, they come to us with pain. So taking a good history of taken on the pain itself is also important. Onset, distribution, symptoms of inflammation, any associated symptoms, severity of the joint pain, and of course, functionality and quality of life. Now, this is quite an important slide because one of the biggest way of dichotomy regarding which part of joint pain is involved is whether the pain is inflammatory or non-inflammatory. And there is a dichotomy between the two, like as in when the inflammatory joint pain, there will be pain that is worse in the morning, it is associated with stiffness that lasts more than half an hour. It causes some nighttime troublesome symptoms and systemic symptoms. And of course, at the other side of the coin is the degenerative or mechanical like pain. Okay. Morning stiffness, now you have to be careful when we ask about the history of morning stiffness, where it's basically the patient will complain of tightness of moving the joints or about to move the joint. That is what we really mean by stiffness. Okay. Examination of the involved joint, we look for redness or synovial hypertrophy, whether there is any swelling or not. And the swelling can be because of the synovial that is hypertrophied. It could be a bony swelling or it could be fluid. So one way of differentiating in the clinical examination that when it's bony, it's hard on palpation, and synovial hypertrophy or fluid, there will be bogginess on the sensation of the joint. There will be some warmth and tenderness, there will be deformities, and of course, extra-articular features. Now, as you can see, there is this thing called a squeeze test which can be assessed at the metacarpophalangeal joints or the MCP joints. So it's basically, as the picture shows, you just press on the MCPs or MTPs. If you elicit pain, then unfortunately, you will have to examine the individual MCPs and MTPs. But if they are negative, then you can concentrate on, you won't have to waste your time basically on examining individual joints. Now, that's me actually. Now, the reason why I put up this picture, the picture on my left, is before I apply pressure on the joint, and the picture on the right is after I apply pressure on the joint. So you want to apply pressure until the tips of the fingers are blanched. That is the amount of pressure that you should apply. If you apply anything more than that, even a normal person will be in pain. Now, this is another schematic pattern for us to differentiate between the various types of joint pains, whether it's rheumatoid arthritis, osteoarthritis, CPPD, PSA, or gout. And you would like to look at the joint distribution, any synovitis, toe 5 or gout, and of course rashes in case it's something like SLE or psoriasis. So finally, we come to the test. Now, I'm a firm believer in taking a good history and examining the patient first. That's my firm belief, and I think it should be taken by most doctors, not the other way around of seeing the blood test before examining the patient. Okay, now, of course, we do the bloods, as in we see the inflammatory markers, whether it's ROCRP. We take into account whether there are things like rheumatoid factor, NTCCP, ANA, CHLB27. Of course, we do X-rays, especially when you want to see for any certain pathologies, but bear in mind that X-rays can be normal in early disease. And of course, our secondary stethoscope now is musculoskeletal ultrasound that can be used to detect pathologies early in the phase of disease. You can use it to monitor disease, and of course, you can use it as part of therapy, especially when it comes to MSK injections. So this is just a simple picture of a normal MCP joint, transverse and horizontal wise. And that just now was a normal joint. This is an abnormal joint where you can see at the MCP head, there is overt synovitis, and the color Doppler lights up, when you put it on, there's a lot of information. Okay, now management, do not underestimate non-pharmacological management because there is a role, where you refer you to your occupational therapist so that the patient can have some functionality in terms of the activities of daily living, such as how to write, how to hold a spoon, how to type, how to do their activities of daily living. And physiotherapy include some form of exercise, wax therapy to reduce the inflammation, getting them up to walk via quadricep muscle strengthening, and so forth. And of course, pharmacological therapy will include mainstay of therapy, of course, will be symptomatic relief, such as painkillers, corticosteroids, and colchicine for those who have gout, and a bit more definitely therapy, such as your immunosuppressive therapy, which can be ranging from conventional synthetic DMARDs or biologic treatment. And of course, in the case of gout, you want to lower the uric acid, urate lowering therapy if it's indicated. So we now focus, just now was somewhat of a brief overview of how to approach joint pains. And I guess now we go to the individual common rheumatological diseases that present with joint pain, beginning with the most used and commonly seen among them is rheumatoid arthritis. Now, I put that rheumatoid factor does not equate to rheumatoid arthritis, okay? Which I will tell you reason why. Now, rheumatoid arthritis, of course, there is a joint involvement, it's a symmetrical polyarticular joint involvement, but bear in mind there are extra-articular features such as subcutaneous nodules, eye disease, lung fibrosis, and skin diseases like pyoderma gangrenosum. So, what happens in RA? So, in RA, there is over-inflammation in the joints, leading to redness and numbness, and finally, panels will form that will finally erode the joint, leading to joint destruction. And I mean, we want to not capture them at advanced stages, of course, where there is a lot of disability and extra-articular features. We want to capture them early, and you want to prevent them from progressing from early phase to advanced RA. So now, this is a slide that I put in because I'm sure for most of us during medical students, this is what we will talk about as in using the 1987 criteria to diagnose RA. Now, I highlight the 6 weeks because in those days, you at least need 6 weeks to diagnose RA, which is where part and parcel we see a lot of patients having a deforming arthritis later on. And this is the X-ray changes that we will see in RA in order of pathology that's involved, beginning with periarticular soft tissue swelling, followed by periarticular osteopenia, erosions, and finally joint space narrowing, followed by subluxation, and of course osteoporosis later on. This is what we see. Now, RA involves periarticular joint disease, whereas there will be periarticular osteopenia and erosion. And this is just another ultrasound, just demonstrate RA. And here is our new criteria that encompasses at least 6 points and above to diagnose as RA. There is a system of scoring them in accordance to how many joints are involved. And as you can see that you don't have to have a positive rheumatoid factor for anti-CCP to diagnose RA, although of course, if you don't have it, the score is less. And you can diagnose RA that is less than 6 weeks because the idea is to catch them early. Okay, here are certain prognostic factors that we take into account. Of course, in our setting, HLA-DR4 antigen is not an easy thing to do, but by the ESR, CRP titer, rheumatoid factor titer is possible. You can always assess the patient for any nodules, whether they have a lot of joint involvement, and of course, constitutional symptoms. Now, this is what I was talking about all this while in terms of a window of opportunity to catch them early, because we do not want them to later on develop severe disease, deforming disease with loss of quality of life and activities of daily living. And RA is associated, aside from those deformed joints, with increased morbidity and mortality in terms of not just loss of function, but extra-articular complications that can be quite debilitating, like lung diseases, osteoporosis, eye diseases. It is of a cardiovascular equivalent in causing heart diseases and also lymphoma. And bear in mind that because most of them end up on long-term steroids and NSAID therapy, the following complications can be seen. Now, principles of management, as I said, of course, pain control with NSAIDs, COX-2 inhibitors, bridging with steroid therapy, and more definitive treatment to modify the disease so that they don't develop joint problems, joint deformities, and also to ameliorate the disease so that they don't get extra-articular complications is conventional synthetic DMARDs. And of course, if they don't work, we go on to biologic DMARDs. Basically, to start DMARDs as early as possible. And of course, supportive therapy with physio and occupational therapy. Now we move on to another disease called Spondyloarthritis or SPA. And one thing you must understand about SPA is a constellation of quite a number of other diseases. There is gut involvement, there is eye involvement, there is skin involvement, there is also axial involvement. And this picture just demonstrates further, that the eye can be involved as in uveitis, you have enthesitis and dactylitis, you have inflammatory bowel disease, you have genital urinary problems, and you have axial disease. Now, as opposed to rheumatoid arthritis, where there is periarticular osteopenia, or the thing that is a bit different is there is inflammation of the periosteum or periostitis in SPA, leading to a periosteal reaction and finally arthritis. And another hallmark of SPA is enthesitis, where there is inflammation of the antices. Now, what we mean by antices? Antices is the sites where the tendons or ligaments insert into the bone. And as you can see here on this picture, the patient has a right-sided tendinitis in the Achilles tendon. And this is what you see on X-ray, because the ends of the bone are inflamed. So finally, they develop those X-ray changes. And here's another ASAS classification criteria. Because the joint involvements are not just peripheral, there is also axial. Okay, it's a bit of a busy slide, but it demonstrates that the patient can have axial involvement, and there are ways to diagnose an axial involvement. There are ways to diagnose if the patient has peripheral arthritis, and there are ways to diagnose if the patient has enteropathic arthritis if it involves the gut. So we'll talk first about the axial involvement, which is ankylosing spondylitis. So it affects young adults. It's a chronic disease, and the hallmark feature is inflammatory back pain. And it is an important finding to actually denote whether the patient's spinal pain is inflammatory or not, because of course there are other reasons like degenerative disease or disc disease. So, and in fact, if you were to look at the previous slides, you always concentrate on talking about inflammatory back pain first. So how to diagnose inflammatory back pain? So according to ASAS, this is what it says, that is the age of onset is 40, or you can even take up to 45 years, but basically 40 to 45 years. It's insidious, there is improvement of the pain with exercise. In fact, resting makes the pain worse, and it wakes the patient up at night. The patient will classically wake up at night and have to pace around the room to actually improve the pain. And you have to have at least 4 out of those 5 criteria in order to diagnose inflammatory back pain. Okay, here is another graph to show the time cost to develop syndesmophytes or sacroiliitis. Now, the reason why it takes about many years for X-ray changes to occur, that is why one of our modalities of managing or diagnosing ankylosing spondylitis is to actually use MRI. We can of course use X-rays, but if you have any problems with any issues, and if there is a high degree of suspicion, then please get an MRI patient. Okay, never mind. I think I accidentally skipped a few slides, but never mind. the management of the ankylosing spondylitis, once it's diagnosed, is actually to put the patient on a good dose of inflammatory dose of NSAIDs. So as you can see by this slide, there is Celebrex of 200 milligrams BD or ibuprofen, diclofenac of 50 milligram PDS, and so forth. I think there is some technical issues here. Just a moment. Just, yeah, and just a moment. There's some technical problems here. Just call them. Okay. Just a moment here. There's some technical problems here. Just a moment. Try to sort it out. Dia macam mana tutup balik? Tutup balik. Okey. Ada buka balik yang mana? Saya. Point. Okey. Okey. Tadi. Sekejap. Tadi. Saya bisa ada tak? Sekejap. Sekejap. Just stop. Isu tu mau slide ada. Memang ada. Mana yang missing dari tu? Okay, I will see this one. Okay, I'm sorry about that technical error just now. But we just go back by a few slides. I just want to show you these two slides about diagnosing someone with excess spondyloar arthropathy. So here there is on my right, there is the old criteria that is used from 1984, which I used when I was a medical student. And here on my left is a more newer criteria. But even then, also with the newer criteria by ASAS, we still use it in terms of when we have to use X-rays to diagnose the patient. But of course, as I said previously, it takes a few years for the X-ray changes to appear. And it is because of that in those days when before the advent of MRI, by the time the patients are diagnosed, they all end up with deformities like question mark spine. So that is why we can actually use MRI. And as I was mentioning before, even before we talk about imaging, we always have to take into account whether the patient has inflammatory back pain first. Then after that, we proceed to do imaging, and of course a few scar features, and of course HLA-B27. So as I said before, X-rays take many years, and we don't want to catch them late. So that's why there is a use for MRI. And this is what we don't want the patient to end up with. You know, this is already there is some degree of question mark spine on this patient. And this is the management that we use now. It's a bit of a busy slide, but I want the audience to just concentrate on these things that I highlighted, to which we all can start first before referring to a rheumatologist and see to stop them from smoking, to put them on physiotherapy for back strengthening exercise, and to start them on NSAIDs or COX-2 inhibitors at an inflammatory dose that I mentioned here. All these are available through the internet. You can just download ASAS and see how much dose of NSAIDs or COX-6 available to you that you can start at a proper inflammatory dose for the patient. Now, we go on to psoriatic arthropathy. As the name denotes, the patient has psoriasis and they develop joint pains. Most of them will have psoriasis first before they have the joint disease, but some of them have concurrent, or some of them even have the arthritis first before they develop the skin disease. And this is a plaque psoriasis on the elbow. And when you talk about the types of PSA, there are 5 types, which is the rheumatoid-like or the symmetrical-like, the oligo-like, which is about 1 joint or 2 joints. Arthritis multilis means telescoping of joints. It's basically like when you unfold a telescope to enlarge your image. This is what is a very debilitating disease. A DIP involvement, and of course axial involvement. So in order to diagnose PSA, there is a criteria that we use. It's called CASPA, and it takes into account whether you have skin manifestation, you have nail manifestation, rheumatoid factor negativity, presence of dactylitis, and also X-ray changes. Now, what do you mean by dactylitis? This is what we call dactylitis, or another layman term called sausage-toes. What means by dactylitis is an inflammation of an entire digit, the finger and toes. And if you have to look closely at this picture, the patient also has some nail changes as well. Now, there was a previous speaker who talked about gout, so I won't concentrate much about gout. I just want to highlight, just that rheumatoid factor isn't the only test that you can use to diagnose RA. You should not rely just on the uric acid levels to diagnose gout. There is a newer criteria of diagnosing gout, consisting of entry, sufficient criteria, clinical criteria, lab and imaging criteria, and thanks to the advent of handphones now, we can even download a proper application at MOHAMMED to help to diagnose gout. This is just to show a negatively bifurcated gouty crystal, how the tophi looks like. It can be monoarticular or rheumatoid-like. It can evolve any place. And I just want to highlight that picture of that young man there with a spine, because this patient actually presented with paralysis because the tophi developed inside the spinal cord. That's the musculoskeletal ultrasound picture of a gout where you have a double contour sign. The erosion, that is a typical upper core erosion. And now we go to osteoarthritis. Osteoarthritis can be primarily because of sedentary lifestyle and aging, or is secondary from inflammatory arthritis. The patient has mechanical like joint pains, inflammatory markers are usually not elevated or even so mildly elevated. What happens in osteoarthritis, because of excess pressure on the joint, they develop spurs called osteophytes as the bone rubs with each other and the retaining of the cartilage. Now, I put up this picture because, oh, sorry, but what I want to show is the DIT joint, you know, that is what we call Haberden's nodes, and it's bony hard. A lot of times people get confused whether this is psoriatic arthropathy or gouty arthritis. Then, of course, there's Bouchard's nodes, which is the PIP joints, which can be confused with rheumatoid arthritis. So this is the picture, or sorry, the X-ray of a patient with osteoarthritis. You can see loss of joint space, subchondral sclerosis, and a cigar pattern appearance in the PIPs here, and some BIP joints involvement as well. This is the knee X-ray of a patient with osteoarthritis, where you can see the subchondral sclerosis and also some degree of osteophytes in the knees. Management is predominantly weight reduction for those who are obese, lifestyle modification to reduce weight, quadricep muscle strengthening, walking aids, and appropriate footwear. So do not underestimate, again, non-pharmacological methods such as quadricep muscle strengthening, which can be done with the patient sitting down or with the patient lying down. Management, of course, is painkillers, some degree of glucosamine or chondroitin, diacylin or plasmodium, intra-articular viscose supplementation, and topical treatment such as ketoprofen patch. A brief touch on the fact that SLE, scleroderma, Sjogren's, and dermatomyositis polymyositis can sometimes present joint pains, particularly SLE. And not to forget of other mimics of joint pains that are commonly referred to as they are just soft tissue rheumatisms, like for instance a trigger finger, decurvating tendinosynovitis, tennis elbow, and golfer's elbow. And last but not least is fibromyalgia, which are also quite commonly referred to as, where they present with pain, but actually the pain is not in the joint, it's more of at tender points. And here is an application that you can use. This is from the older version of the application, but it's about the same anyway. It's called Rheuma Helper. And as you can see, there are things that you can use inside to diagnose the patient, and of course, disease activity. And as you can see, there are ways that you can use the app to help you to diagnose classically the axial spondyloarthropathy, gout, PSA, RA, SLE, scleroderma, inflammatory back pain, and so forth. With that, I end my presentation, and I will welcome any questions from the audience.
Thank you very much, Dr. Malek. So now we will move on to the question and answer session. So hold on, yeah, we're looking for the question corner here. Maybe Dr. Nina can help out. I can't see any of the questions being posted up here.
Yeah, I think there are no questions posted for today's session actually.
All right, okay.
Yeah,
Well,
it should be in the Q&A section, yeah.
okay. So perhaps I think everybody understood well what Dr. Malek has presented, but perhaps I can just give a bit of summary of what Dr. Malek, how long can we offer NSAIDs to patients? Yeah.
Okay, there is a question there that says that how long can you offer NSAIDs to patient? Well, there is no proper answer to that. After all, NSAID therapy is a bridging therapy to offer some pain relief to the patient. We should try to minimize the duration of NSAID therapy as short as possible. However, there are conditions where you have to offer chronic long-term NSAID therapy, which is in this case if the patient has ankylosing spondylitis, where you have to put the patient on long-term NSAID therapy. And the NSAID therapy is not even PRN, it's anti-inflammatory dose. However, once the patient has attained remission with the NSAID therapy, then the NSAID therapy can even be tapered down to a PRN dose, while maintaining the patient on, of course, physiotherapy for the back.
Thank you, Dr. Malek. Yeah, there's another question. Can we avoid joint aspiration in the diagnosis of gout using the clinical criteria and start ULT according to indication?
Okay, that is a good question. After all, joint aspiration is an invasive thing, but joint aspiration, of course, is also beneficial because if you already have a clinical criteria, as in pain, and you happen to aspirate the joint and you demonstrate the crystals that are pertaining to gout, then you already can diagnose the patient to have gouty arthritis. In fact, when you aspirate the joint, you can even see whether there is, especially if you have a patient that is suspicious of an infection, it is almost a must to aspirate the joint in order to identify any bacteria or any germs in the joint. But of course, if the patient is not keen, then of course there are other criteria that we can use in order to treat the patient for gout. Now, there is another question that says how to differentiate between psoriatic arthropathy and spondyloarthritis. Well, in order to differentiate, of course, we have the classification criteria that we have already put up. For psoriatic arthropathy, there is a CASPA criteria. For the spondyloarthropathy, there is a criteria that I put in the slides from ASAS, which we can apply. But just bear in mind that patients with psoriatic arthropathy can have axial symptoms. So that's my answer to that. And then there is another question. If the patient is diagnosed with RA, what dose of prednisolone and methotrexate to be started? How is the titration and how fast? Okay, this is a good question. You have already diagnosed the patient with rheumatoid arthritis. So, of course, because methotrexate or any other conventional synthetic DMARDs will take time to kick in and win out its effect, it takes about, for methotrexate, maybe about 2 to 3 months before the effects can really go in and the patient can feel some difference. So definitely you can use prednisolone, and usually we find that a dose of 10 milligram and not more than 10 milligram will be enough per day, will be enough to actually control the symptoms, which can be tapered down. In terms of starting methotrexate, we believe in starting methotrexate and escalating it to a good dose, which usually start at 7.5 milligrams per week, and we up-titrate, if possible, to a dose of from 7.5 to 10 to 10.5 to at least around 10.5 to 15 milligrams per week in a 2-weekly manner, while monitoring the patient's fluid count and liver function test 2-weekly as well. Another question, does a patient with IBD more prone to have psoriatic arthropathy or ankylosing spondylitis? Good question. Actually, IBDs are prone to, can develop both, because inflammatory bowel disease are actually part of the SPA pool. And some patients with psoriatic arthropathy or ankylosing spondylitis can even develop inflammatory bowel disease. So it goes both ways around. Okay, that's the last question so far. Any other questions?
Any other questions for Dr. Malek? I think there's one more down here. Yeah.
Oh, do we serve supplement? Okay. Now that's a good question. In terms of giving supplementary folic acid. Now, folic acid, yes, we serve folic acid when they are on methotrexate. So there are many ways of using it, but the golden rule is never to give the folic acid and the methotrexate on the same day. Methotrexate, as you all know, is taken once a week. So it can be on any day from Monday to Sunday. So let's say the patient is taking methotrexate on every Mondays. So we just tell the patient, we tell the patient to take the folic acid on other days aside from Mondays. And some will give once a week, some will give twice a week, some will give every day, except for the day that they take methotrexate. Okay.
But I mean, for that one, things are actually changing, you know, so a lot of things are evolving. And in fact, lately they're saying that no much of a harm if you were to give the supplement of folic acid on the same day. So things may not be the same later, you know. So another example like for gout, yeah, since one of the questions was gout. Last time, what we mentioned was when you initiate the urate lowering therapy, previously we said do not initiate during the acute attack. But now things have changed, you know, so you can actually initiate during the acute attack, but with the prophylaxis, because there are pro and cons to it. Yeah.
But but as what Dr. Biba mentioned, just inform the patient, you know, to take the colchicine while on the allopurinol. Okay. Does there any difference in terms of management in patient diagnosed with axial or peripheral ankylosing? In terms of management, there are differences. With axial involvement, the management is basically NSAID therapy or COX-2 inhibitors at a proper anti-inflammatory dose. And when there is no, and of course along with physiotherapy for the back. And later on, when there is no response, then you have to escalate to biological DMARDs such as infliximab, adalimumab, or IL-17 inhibitors. In terms of peripheral ankylosing spondylitis, there is a role for NSAIDs, but only as a pain relief. And there is a role to actually put the patient on conventional synthetic DMARDs, usually sulfasalazine. And of course, if the patient doesn't tolerate or is contraindicated to sulfasalazine, methotrexate. And of course, when there is no response to treatment, then of course there is a role for biologic therapy.
Sorry, Dr. Malik, I would like to add on a bit to the clinical criteria. Actually, there is a criteria whereby you can diagnose gout without the joint aspiration. And according to that criteria, when you have 2 out of the 4 criteria, you will be able to make a diagnosis. The 4 criteria are when you have clear history of 2 painful joint attacks with complete resolution within 2 weeks, clear history of podagra, presence of tophus, and rapid response to colchicine within 48 hours. So if you have at least 2 out of the 4 criteria for this patient, even without having a joint aspiration, you would be able to diagnose these patients with a gout. Yeah. Okay, as we move on, Dr. Malik, there's another question here.
Okay. Okay, this can rheumatic patients take COVID vaccine? All right, is that now the very fact that our rheumatic patients are immunosuppressed either from the disease itself or from the immunosuppressive therapy that is given, actually they are actually indicated to receive the vaccine to prevent them from getting COVID in the first place. It's just that there is a certain timing in terms of taking the COVID vaccine, depending on what immunosuppressive therapy that the patient is on. For instance, if the patient is on methotrexate, we advise them to have the vaccine taken, but to omit the next dose of methotrexate. Certain immunosuppressive therapy like hydroxychloroquine, there is no need to adjust the dose or adjust the timing of taking the medication. To which we have, I think, already produced a consensus, a Malaysian consensus on that.
Yeah, I would like to take this opportunity to inform everyone that our rheumatologists have sat together and we have actually come up with a consensus, and we have actually circulated the consensus whereby rheumatological patients who are considered autoimmune or immunosuppressed can be given the vaccination, and they should be considered as one of the priority. So I hope this message can be get put across to the others as well, because some of the patients are so worried to get the vaccination.
Any DMARDs particularly helpful for joint pain in those with SLE? Okay, for SLE, the DMARD that we usually use to help them with the joint pain is the hydroxychloroquine at a dose pertaining to their weight. Most of the time, this is more than enough. If let's say the hydroxychloroquine is not enough, then we also use other DMARDs such as methotrexate.
And sometimes certain things that we have to remember, the joint pain, when patients present with joint pain, it may not be purely a joint problem. Yeah, I think there's another one question. Okay, because perhaps while waiting for the other questions, I can share. Recently, there was a patient who was referred to us for rheumatoid arthritis, and eventually, because patient has got other problems as well. Patient has got hypothyroidism and things like that. So eventually, it was the hypothyroidism which was poorly controlled that gave rise to this kind of a pain, joint pain, not so much swelling. And when the underlying hypothyroidism was treated accordingly, patient's joint pain has actually subsided. So sometimes we have to look into the patient as a whole. What are the problems the patient has, and not also, I mean, sometimes you have to not forget other things like HPOA and do the appropriate investigations when necessary. Yeah, Dr. Malik, anything else you would like to add? We've got a bit of
another one that I like to actually highlight is like my very first slide, infections. You know, infections are quite common, and of course, if you miss an infection and actually put the patient on immunosuppressive therapy, then it can give rise to certain problems, like the problems that I remember when I was in my training like 5 years ago, there was a patient who presented with just a knee swelling, and the X-ray shows he had TB. And true enough, when we did a synovial biopsy of the knee, the TB has gone to the knee as well. So we actually treated the patient as such for TB of the arthritic TB, and the patient responded to anti-TB treatment.
So far, there's no other questions. But of course, what we usually, I mean, if let's say you are in doubt, refer. You know, it's better to overdiagnose rather than patients coming in late, because we do not want to see them at a later stage when the joint damage is done and will be at loss. So if you're in doubt, you're not sure, either you can refer or you can actually call one of us to discuss these cases. We are open to discussion, yeah. And maybe since now, okay, there's another question.
For patients with RA, how long does one keep a patient at good? Let's say one make assessment. Okay, the question is kind of a long one, but it basically says that how long can the patient be on a methotrexate, a good dose, before you consider a poor response? Basically, methotrexate takes about 2 to 3 months to kick in its effect. So after a good dose and the patient is compliant, about 3 months at least around there, then you do consider to either escalate the dose or add in other DMARDs. Bearing in mind that with methotrexate, anything above 50 milligrams, sometimes there is a plateau of response. And the other thing is, whenever we are faced with this problem, always don't forget to ask whether the patient is compliant, because nausea and vomiting is a very, very common problem with methotrexate. So there are many ways of giving the methotrexate. Either you split the dose or you give subcutaneous methotrexate before you really say that the patient is not responding to the treatment. Other than clinical resolution, does one diagnostic progression? Yes, of course. Inflammatory markers are one of the ways that we use to treat the patient. But bear in mind, when you have a patient who has good clinical resolution, but the inflammatory markers are raised, then there might be other reasons for the inflammatory markers to be raised, such as, of course, first and foremost, infection. It can be also because of other conditions like lymphoma or malignancy. And do listen to the lungs, because when the RA patients start to develop lung fibrosis, the ESR and CRP can be elevated too. Now, does supplement like glucosamine or calcium helpful for knee OA? Glucosamine, yes, there is a role to give glucosamine in knee osteoarthritis. You can give and you can see whether there is a response within 2 to 3 months. If the patient doesn't respond, then most likely it's not helping. But bear in mind that it is not the only modality of treatment. Quite a number of times the patient actually have overweight or obesity. And bear in mind also the degree of the knee osteoarthritis. If you are dealing with someone at grade 1 or grade 2 knee OA, then maybe it's helpful. But if someone is already at grade 4, then you might as well refer him or her to the orthopedics for the knee replacement. Another question is, what type of intra-articular injection is recommended in osteoarthritis? Well, about a few years ago, we actually published our CPG on the management of osteoarthritis. So we usually inject a combination of lidocaine and triamcinolone to the joints involved. But there are also some thoughts of viscose supplementation, which can be used, but whatever intra-articular injection, whether steroid or viscose supplementation, varies in terms of response. Within some 6 months, some 3 months, some none at all. And I think you still have to go back to see what type of degree of osteoarthritis you are facing, as well as taking care of other things such as obesity. Any proven treatment that is most helpful for hand OA, especially for the pain? Not really so. Not really so. Even the glucosamine also, there's not much proven benefit. It's most likely pain relief and things. And you can also refer the patient to the physiotherapist for things like wax therapy to improve the pain and also reduce the pain. And the other thing, because it's involving the hand, you can refer to the occupational therapist so that they can teach the patient joint protection strategies and adjustments to their activities of daily living using their hands so that they don't damage the joint further.
There's another question here, Dr. Malik. Rheumatoid factor and serum uric acid co-positive. Any opinion on this? Meaning that the patient's having both rheumatoid factor and serum uric acid. It was WhatsApp in the WhatsApp group.
Oh, sorry.
That's the question.
Oh.
So if like, can a patient have both rheumatoid factor and uric acid being positive? So what is your opinion on that?
Okay. Bear in mind that rheumatoid factor can be falsely positive, especially in elderly populations. And bear in mind that taking in rheumatoid factor alone to diagnose rheumatoid arthritis is the main reason why my first slide on rheumatoid arthritis is that RA doesn't equate to rheumatoid factor all the time. Now, with regards to the uric acid, it's, as I said in my slide in gout, that uric acid, high uric acid levels do not equate to gout. There are other things that can actually push up the uric acid, such as CKDs and certain medications like thiazides or pyrazinamide and so forth. So at the end of the day, that is why when we talk about the assessment, I am a firm believer in, and I think it should be transmitted across, that you have to examine the patient first, take the complete history, and then take into account the blood test results and come up to a proper conclusion based on all modalities involved.
And just to add on, the uric acid level fluctuates very much, So even in a patient who's got gout, the uric acid level being low does not rule out gout. So I think for a patient who's got both, which is positive, clinical history, clinical examination is very important. Most of the time, we hope that the patient doesn't have both pathology.
Of course.
But there are very few instances whereby patients may have it both, but we have to see which is the most likely the diagnosis. Yeah.
So maybe you know about that. So any more questions?
Any other questions? I think with regards to methotrexate, I can say, sometimes it's quite a challenge for us when patients are on methotrexate because quite a number of times patients' compliance are very good. Dr. Malik?
Yes.
Yeah, so you have to keep reminding them. You have to take it accordingly because the stage of the MCX perhaps one of the reasons why patients may not be compliant. So if let's say you were to treat this patient, we have to reinforce again.
The other thing is sometimes they even look at the methotrexate is really enough to make them nauseated. So that is why, as I mentioned, there are other ways to institute the methotrexate, either in a split dose or a subcutaneous formulation.
I was told that there are 200 plus participants for today, so I hope this session has been quite helpful. Okay, any contraindicators? Okay, next.
Okay, contraindications to start DMARDS. There are a few contraindications to start DMARDS. And when you talk about DMARDs, what are the indications, pertaining to each disease? So, for instance, certain DMARDs are contraindicated in certain conditions, such as, for instance, if you talk about methotrexate, it can be as simple as someone who really just cannot take the methotrexate, or if someone already has a severe lung fibrosis. As you know, methotrexate can induce lung fibrosis. There is also a thing of dose reduction in certain DMARDs. For instance, in methotrexate, when you have CKD, you have to reduce the dose. If the patient has severe uncontrolled hypertension, there might be some worries to actually start certain DMARDs like cyclosporine or leflunomide. Again, when the patient has renal impairment, you have to be watchful of cyclosporine. Methotrexate also, if the patient has significant liver disease or bone marrow suppression, then you have to either not start or be watchful after you start.
But in general, all our patients, before they are being started on DMARDs, we screen them for hepatitis screen. That is mandatory that we're doing.
Yeah, that's in fact one of our KPIs. That any patient to be started on DMARDs, particularly biology DMARDs, to be screened for hepatitis B, hepatitis C. TB is another one that you are worried when you're talking about biology DMARDs as well. And of course, a baseline renal profile, full blood count, liver function test, and so forth.
There's no other questions. I will pass over to Dr. Mina, is it?
Yes. Right. Thank you very much, Dr. Malek and Dr. Habibah, for the very informative session. And I hope all 200 plus participants today have benefited from that. Now, for those who are with us today, there's a recorded session uploaded on YouTube as well. So you can, for those who have missed it or perhaps missed half of it, you can have a look at that as well. And the QR code is now on the is on now. You can use that to collect your CPD point as well. Okay. And I think that's all. So please stay tuned for next week's. We will be talking about SLE. Okay. Thank you very much. Thank you, Dr. Malek again. Thank you, Dr. Habibah.
Thank you. Thank you all. I buat tu je.
Itu je. Tapi saat ni boleh I can save into my thumb drive also lah. I got my thumb drive there.